Hello, and thank you for joining today's program on neuropathic pain, treatment options, cost considerations, and current limitations, presented by the Foundation for Peripheral Neuropathy and generously sponsored by Eli Lilly. I'm super excited to welcome our expert speaker, Dr. Brian Callahan from the University of Michigan, to discuss different ways to treat nerve pain that are supported by the American Academy of Neurology. We will also look at how much these treatments cost and what they mean for patients. Finally, we'll explain what results people can expect from these treatments and some of the limits they may have. My name is Lindsay Colbert. I am the Executive Director of the Foundation for Peripheral Neuropathy. On behalf of the organization, its staff, and dedicated board members and volunteers, I thank you for entrusting us with providing valuable educational resources as you navigate your journey living with peripheral neuropathy. Before we begin today's program, I just want to quickly remind everyone of a few logistical items. First, yes, we are recording today's program, and it will be emailed to all registrants and also permanently housed on the Foundation website, along with the accompanying slide deck for future reference. Second, for those who are in attendance live today, we will be carving out time at the end of the presentation for a live Q&A. Please use the questions box in the dashboard of this platform to ask any questions that are general in nature and on topic. We will not be able to answer any personalized medical questions today, rather answer questions that are helpful to the greater audience. And third, yes, we do offer closed captioning for those who are in need, and that can be switched on in your dashboard as well. And now I'm pleased to welcome and introduce our expert today. Dr. Callahan is Professor of Neurology, the Eva L. Feldman Professor of Neurology, and a staff physician at the Ann Arbor Veterans Affairs Hospital. He has over 160 peer-reviewed publications, including more than 40 first and last author publications. He has received grant funding from the NIH, VA, ADA, JDRF, and the AAN. He serves on the editorial board for the Neurology Journal. Dr. Callahan also serves as the chair of the AAN Health Services Research Subcommittee, the vice chair of the Peripheral Nerve Society's Scientific Programming Committee, and a board member for the International Diabetes Neuropathy Consortium. He is the co-director of the Neuromuscular Division and the associate program director of research for the Neurology Residency Program. We are extremely lucky to have him speak on this topic. And with that, I'm excited to pass the virtual mic over to you, Dr. Callahan. Thank you again.
Thanks so much, Lindsay. I really appreciate that kind introduction and look forward to talking with you guys today. So Lindsay's already told you the topic, so I'm going to dive right in. Except my mouse is not activating.
Oh, it's not working. Sorry about that, Dr. Callahan. We're going to try to push it again on our end. 1 second.
And that gives me time to explain that it is not June 19th. That's just when I put the slides together. So it is July 10th for those that are trying to figure out what it says that.
Still yeah, that's okay. Oh, shoot. Well, we did send over the control. Apologies, there's a little...
It says, yeah, I accepted it, and it did activate on the bottom, but it's not actually going.
Maybe click on the presentation on the screen itself and then try to use the arrows. And if it still doesn't work, just know that we'd be happy to.
There it goes.
There you go. Okay, good.
Third time's the charm. So
exactly.
For neuropathic pain, I'm going to describe, what is it? How is it different from other types of pain? How do you treat it? How much does it cost? What are some of the unique challenges we deal with? And then hopefully get to some of the promising future options that we have. So neuropathic pain is a relatively simple definition, and that it's really injury from anything that affects the nerves and leads to pain. And how we kind of figure it out is it's really in the context, what else is going on. So this kind of pain is the pain that's often associated with other things that happen when you have injury to nerves, such as numbness, lack of feeling, tingling, pins and needles, and itching. Furthermore, sometimes people have the sensation where something that wouldn't usually cause pain actually becomes painful. And because we're doctors, we have to come up with a fancy term, so we call it allodynia. The type of pain is different than some pain from things that aren't from nerves. From when it's dealing with nerves, it's really burning, electrical, stabbing, and sometimes painfully cold as well. As far as how this differentiates from other kinds of pain, there you can have pain that's caused by things in your skin, problems with your joints, problems with your bones, and then something that people don't think about enough is central pain, where it's really how we process things in our brain that causes pain. The most common of which is called fibromyalgia, but there are several kind of conditions in that group of disorders as well. Again, it really is the context. What else is going on? What other symptoms? What other things we find on exam? And the type of pain when it's from these different parts of the body tend to be different as well. When you have joint pains, it tends to be throbbing and more of a dull, achy kind of sensation. And when it's in the skin, a lot of times you'll have itching, or the pain is more surface level. So, before we decided to tackle this topic, it had been well studied. So here are just 5 studies in very prominent journals that show that they kind of went through the entire literature and tried to figure out what works for neuropathic pain. And the nice thing is the results were pretty consistent across these 5 studies. And so we decided to kind of take it one more step further in a few different ways. So we wanted to look at classes of medicines rather than individual medicines to see, does it matter if you're on a particular medicine, or does it more matter the class of medicines that you take? We also wanted to combine all the data that we have together and do statistics on pooling it together rather than just looking at the individual studies. And we wanted to look at studies that didn't really have a placebo response. So if you have a pain study without a placebo response, it's probably not well done. And we also wanted to address the opioids as well. Sorry, and I can't tell if I'm advancing the slides, because if I am, it's going very slow, or if someone's doing that for me.
Yes. Dr. Callahan, we're not doing it for you, but if you are finding it to be a challenge, we'd be happy to do it on your behalf. Just let us know.
It's just going very slow, so
I've
it's
noticed that too. I'm so sorry. How about, would it be okay if we just advance your slides moving forward?
yeah. If it goes faster, let's see if that works. So
Let's give it.
this is this kind of one slide that summarizes so much of what we know about medications in neuropathic pain. And this is particularly for painful diabetic neuropathy, but also applies, I think, to all neuropathic pain. And what you can see, I think, is that these blue dots kind of show you how much these medicines help patients with pain. And if those error bars cross 0 to the far left, then they probably don't work. But all these work, and they all line up about the same, right around that 0.5, which it's hard to explain what that means, but these are all modestly effective. They work a little bit, not a lot. So they're not perfect. But you can see that gabapentinoids, SNRIs, sodium channel blockers, SNRIs with opioids, kind of a combo, and TCAs, which are tricyclic antidepressants, all these work about the same. The TCAs are a little bit to the right, mostly because we haven't studied them as much. And you can see those bars are really wide, meaning I think if we did more studies, the bars would start to come together and it would shift over to the left just like the other ones. So we do have these 5 classes of medicines and they all work a little bit for neuropathic pain. Next slide. Great. So this is another way of looking at the same data, but I just wanted to show that when you add it all together, we've studied these in lots of patients. So we're talking about 16 trials that have been done in gabapentinoids, 5 for the sodium channel blockers, 9, etc. And then the total number of patients is in the thousands. And this is just for painful diabetic neuropathy. If you start to include other types of neuropathic pain, the numbers of studies and patients goes way up. So this is incredibly well studied. Next slide. This study is one of the rare studies where they actually did some of our best medicines and compared them head to head. Because I showed you that they look like they work about the same when you look at the individual studies, but it's always a potential that there's something different about the investigators or the patients it was done in. But this was done in one study in the same people, the same investigators, and they did amitriptyline, which is a tricyclic antidepressant, pregabalin, which is a gabapentinoid, and duloxetine, which is a SNRI. And what you can see in the top panel is that these are identical. There's 3 lines there, but you can almost not see that there are 3 lines. So they all take you from a pain of about 6 to a pain of about 3. So that's the good and bad. It doesn't go to 1 or 0 for most people, but it does work. And these work identically, the same amount. And in the bottom panel, we found out that for the first time, if people aren't doing well with the first one, then if you add a second one, you get a little bit of benefit. On a 10-point scale of pain, it goes down 1 more on average. So you can see that that's on the left, you have amitriptyline in the dark blue, and if you add pregabalin onto it, the pain relief goes down about 1 point. Next slide. So this is another one of my favorite studies because, again, they looked at 4 different medicines, which are really all 4 classes that we have good data for. The 5th class was the ones that include opioids and SNRIs together, and we'll talk about that later. But in this one, they did nortriptyline, which is a TCA, duloxetine, which is an SNRI, pregabalin, which is a gabapentinoid, and mexiletine, which is a sodium channel blocker. So we have 4 different classes. And what they found is that nortriptyline and duloxetine were better than pregabalin or mexiletine by a little bit. The reason there was a difference, though, is the real important thing here, because this was a pragmatic trial, not like a traditional trial. So it was more of a real world type study. And what they found was people didn't stay on pregabalin because a lot of times they had problems with insurance because it was expensive. And so we should really think about how expensive these medicines are, because it has real effects to patients, not just how much they pay, but whether they even stay on it. And then mexiletine wasn't quite tolerable compared to the other ones, so people stopped it more. But if they were able to take it, it worked just as well. And we have other sodium channel blockers that have better tolerability. So we're still learning that these medicines are about the same, but there are some nuances when it comes to cost and how much people can tolerate it. Next slide. All right, well, I've been telling you a lot about medications because medications are mostly what doctors and patients talk about. But there are other things besides oral medications that can help with neuropathic pain, and it's important to know about them. One of those is topical capsaicin. This is something that you rub on your body where it hurts. It's available over the counter or by prescription. And there are a couple studies that show that it works a little bit. Maybe not quite as much as oral medicines, but pretty close, and probably has less side effects because it's something you rub on your body rather than something that you take as a pill. Some patients prefer topical. This would be a good choice. This has been around forever, so it's very, very inexpensive and even over the counter. It's a little harder if the pain's everywhere or if the pain is in your entire arm or entire leg, because you have to rub it on those areas. There is an 8% patch that has to be put on by a medical personnel and is very expensive. But there's also these cheap creams at different doses that you can get over the counter in the drugstore. And there's no real reason to suspect one's better than the other. Next slide. Another thing that people are interested in is are spinal cord stimulators. And there was a big study just a few years ago that was published. And what this shows is the pain from 0 to 10 on the left. And so you can see that at the top is 10, here's 0. And CMM just means people got their typical care. And then you can see the bottom line is the spinal cord stimulator. And you can see that the spinal cord stimulator made the pain go from 7 to 2. And people that didn't get it, it didn't change at all. So the problem with this study is that it was open label. And so people knew which one they were getting. And so you can see there's no placebo response. And it's really hard to do a pain study without a placebo group. And so I don't know that we know whether this works or not. People got excited about it. But then I think the next slide will show why I'm a little skeptical. So this is a little confusing slide. I'm sorry that I probably should have circled some things. But if you look at, this is another neuropathic pain condition, radiculopathy. So that's when you have pain due to a nerve root irritation that starts in the back and goes down the leg per se. And they decided to do spinal cord stimulation versus a sham. So both people had a stimulator and they were both stimulating, but one was doing it in the way that was supposed to help and one in a way that wasn't. So patients really had no idea what was going on. And in this case, there really was no difference between the spinal cord stimulation and the placebo. So both reduced the disability 10 points, and both took pain from about a 7 to about a 6. So pretty modest and no difference between placebo and the stimulator itself. And so that's what we find a lot is in these device trials, people do kind of poor studies and it looks promising. And then when we do really good studies, it looks less promising. This is particularly important because spinal cord stimulators are a big neurosurgical procedure. They're costly, there's side effects. Sometimes people get infected, sometimes they have to be removed. And there's some data to support that. There's some clear downsides to putting them in as well. So I think the jury's still out, but right now we don't have good evidence to support it. Next slide. So, I like to talk about costs. No one else seems to like to talk about costs amongst the medical community, but I think patients care a lot, and I think there's some good lessons here too. So I already told you that all these medicines, work about as identically as you can possibly know, but here are the cost differences on a monthly scale. So the scale is, you see 100, 200, and 300 at the top. So we're talking about $300 a month. And costs have only gone up. This study is almost now 10 years old, and so now we're talking more like $600 a month at the top of this scale. You can see that when something becomes generic, so if you look at gabapentin in the green, it takes, it goes generic in 2004, and then a handful of years later it becomes cheap and joins all the ones at the bottom. Then the vaccine became generic in 2009. And then a handful of years later, it becomes cheap. And then pregabalin and duloxetine were just about turning generic around this time and are now, after a handful of years, would join these other ones in the bottom right. But we're talking about the difference between, $10 and $30 a month versus $300 a month in 2016, and now, probably double both those values, $600 and $20. Depending on if you're doing a brand name medicine like pregabalin and duloxetine were, or generic medicines. And so, of course, there's always going to be new medicines that come out in these classes, and they're going to be very expensive, and there's going to be no reason to suspect that they'll be better than the ones that are so similar and have been around a long time. Pharmaceutical companies will also do extended releases, which again makes them super expensive. But don't tend to help with the pain any more than the non-extended releases. So it's something to watch out because it can have major impacts on how much you have to pay. Next slide. And it turns out this is the slide of how much patients have to pay. So the first one was how much it costs if you had to pay all of it yourself. Now this is the one, is how much do patients actually pay? And you can see it is lower. The cheaper ones are in about $10 a month, like you're paying a copay, and the more expensive ones were going up upwards of $70 a month. And again, this only goes up and up over time now that this is 10 years old. And it's completely proportional as far as duloxetine and pregabalin and the other ones. You can almost superimpose the last two slides as far as costs. So it's just we're just passing extra costs on to patients. Unfortunately, we do it in a really random way where some patients pay a lot and other patients pay very little. I'm showing you the averages, but there's a lot of variability and it affects patients very differently. And doctors almost never know how it's affecting you individually. So you have to bring it up, otherwise we're going to be clueless. There are 9 major insurers in the state of Michigan, and each of those has at least 10 plans. So you're talking about over 100 different insurance plans, probably 200 or more. And so doctors are not going to be able to understand that it might be free for you and very costly for the next patient. What we can do is prescribe generics that have been around for over a handful of years, and then pretty predictably they're cheap. Next slide. So my strong advice is that there's no need currently for brand name medications. I'm hopeful that there'll be a new brand name medication that is way better than what we currently have. But right now we have a series of medicines that work about the same and have been around a long time, and we have cheap options in all those classes. And yeah, that's the next point. We have cheap pills available and everything that we need. We also have 2 cheap topical options. I talked about capsaicin and how there's an expensive version and a cheap version. And lidocaine's the same story. So there is a over-the-counter 4% lidocaine patch that's very cheap over the counter, and a 5% prescription that can be quite expensive. So no doctor thinks there's a difference between 4 and 5%, but that's how it is. So get the capsaicin over the counter and lidocaine patches over the counter. Save money, and these are both good options if you prefer topicals. The other interventions are a little harder to discuss. Acupuncture, cognitive behavioral therapy, and mindfulness are much more variable about whether they're covered for people or not. And so some people would have to pay a lot of money and some people not at all. And so it's a little harder to talk about costs when it comes to these other options, which I think are important. Next slide. So one big takeaway I think that's come out of the last several years is that we really need to discourage opioid use for neuropathic pain, for chronic neuropathic pain. Opioids are really good for acute pain that ends up in the emergency room. They're good for pain that's short in duration. They're good for pain at the end of life, but they have so many problems and they don't work nearly as well as we need them to. So you can see here that doctors kind of decided in 1999 that we should start prescribing opioids more and more frequently. And there was really just a skyrocketing of overdoses over the next several years. And that just kept going up and up and up. And only recently it started to come down as people have become more aware of this issue. And there's been a lot of backlash to physicians being a little too free with prescription opioids. Next slide. And this was a good article kind of showing what I think goes into this, which is, opioids do work for pain and about the same exact effect size as the other things we talked about. The problem is that the effect probably wears off over time and people need just to get higher and higher and higher doses. But the real problem is the other end of the balance, where you can see that people die because of opioids. There's overdose and other problems that can happen, like heart attacks. And problems with your endocrine system. People can become dependent and addicted, and there's other loss of family and community that can happen as a result of opioids. So it's pretty much a slam dunk that the downsides far outweigh the benefits. Next slide. And this is a slide showing that in 2016, and there's more recent guidelines that didn't really update this at all, that when you look at do opioids work in the long term? They work in the short term, but do they work in the long term? you can see that there's no evidence to support it. And this is for chronic pain in general, not just neuropathic pain, but chronic pain overall. So we just really don't know if it works in the long term, which is problematic because we know of how many long-term problems there are. Next slide. And that's kind of summarized here. Again, a busy slide, but if you look on the left, abuse, addiction, overdose, fractures, myocardial infarction means heart attack, endocrinologic harms is kind of a broad category of problems with erections or testosterone. And you can see that we have lots of studies and very clear evidence that opioids are harmful on all of these things. So we have no information that it works in the long term, but a ton of information that it has a lot of problems in the long term. Next. And that's kind of a good segue to talking about the SNRI opioids. So SNRIs are duloxetine and venlafaxine. They've been around a long time. SNRI opioids are basically tramadol and tapentadol, two medicines where they do have SNRI mechanisms and opioid mechanisms. Now it turns out that they both work, and then if you combine them, they work. They don't work any better than them individually, so there's not really any added gain. And what you do get is the long-term side effects of opioids. So there are 4 studies showing that these work, but it's my strong recommendation that we don't use these for chronic pain, including chronic nerve pain. And I think this is a good way that they've kind of convinced doctors that these medicines aren't really opioids, and therefore we can use them much more liberally. And that's not really the case. Next slide. And that's shown here. So this is comparing tramadol to naproxen, which is a non-steroidal, kind of like ibuprofen would be. And you can see that there's 1.7 times more likely risk of death when you take tramadol versus taking an NSAID. And when you compare tramadol to codeine, which everybody knows is an opioid, it doesn't have a mixed mechanism, then it's identical, right? So there's nothing special about tramadol and tapentadol. They're opioids. They're not, they're usually at relatively lower doses, but they have the same risks and downsides of other opioids. Next slide. All right, and well, the problem with that is that people with neuropathy, at least, which is one of the most common cause of neuropathic pain, that people are often on opioids. So this was a study done by the Mayo Group, which showed that about half the patients are on opioids if they have neuropathy, and 20% are on it chronically over 3 months' time. So we did this same study in a different database and found the exact same numbers, that there's just a lot of people on opioids. This has gotten a little better over the last few years. We've studied that as well, but we still have a big problem kind of getting our patients off opioids after doing them a disservice, getting them on it several years ago. Next slide. And this is a busy slide, but it's kind of showing, do opioids help people with neuropathy and pain? And the answer is no. So if you look at the far right, none of these odds ratios really show improvements on patients with opioids. So opioids don't improve how people do with all these tasks, like does it help you function better preparing meals, dressing, housekeeping, bathing, etc. Does it help you with pain itself? But all these kind of functional things that you have to do every day, and the answer is no. Next slide. In contrast, the Mayo Group showed that being on opioids increases your chance of having depression, increases your chance of alcohol abuse, obviously opioid abuse, other substance abuse goes up, although not quite significant, and people have more dependence as well. And here's a slide, again, a little outdated, and these things kind of have leveled off, both for gabapentin and opioids. But the pink is opioids, and the green is gabapentin. And what you can see is for painful diabetic neuropathy, opioids weren't prescribed much in 2000, but have really launched off and then kept going up for a few more years, and now have come down a little bit, but we're nowhere near how we were in 2000. And gabapentin has gone way up as well, which is good. Gabapentin works. What I find interesting is that, doctors kind of all practice the same. So every doctor seems to prescribe gabapentin first, even though it's no different than the others. And then the second most common practice pattern is to start with gabapentin, and if it doesn't work, give pregabalin, which is Lyrica. So we're talking about Neurontin and Lyrica. The problem with that is they're almost the exact same medicine, and so it doesn't make a lot of sense to go from Neurontin to Lyrica, gabapentin to pregabalin, but that is the most common thing by far that neurologists do and other physicians. So what would make more sense is to start with gabapentin or duloxetine or venlafaxine, doesn't really matter. And if it doesn't work, switch to a new class of medicines. Next slide. So here's our kind of how to treat neuropathic pain. And I apologize that there's medical jargon like TCAs and SNRIs, but it's kind of hard to talk about these without giving them names like that. But you can see we have 4 classes of medicines that work. And I didn't tell you earlier, but there's no difference between the ones within a class. So venlafaxine and duloxetine are SNRIs, and they work about the same. Amitriptyline and nortriptyline work about the same. Gabapentin and pregabalin work about the same. So it really makes sense to choose based on class. And we have 4 that work. The 5th is the SNRI opioids, which we don't think you should use, which is at the bottom. We don't think opioids and tramadol and tapentadol included, we don't think those should be used. Now, if they don't work, we should try another medicine. If it doesn't do anything, we should just stop the first one. But if it works a little bit, which is a lot of times what happens is it works a little bit, but not a lot, then doing a combination makes a lot of sense. And now we have data that supports it for the first time in the last couple of years. I think this next category is really important because what we find is a lot of people don't do well on the medicines, the topicals, like they try all sorts of things and nothing really works as well as we want it to. And that leaves people looking for other answers. And we do have non-pharmacologic options, so non-medicine options. Obviously, there's capsaicin and lidocaine, which are medicines, they're just topical. So I think those are really good because they have less side effects, because you don't ingest them, you don't eat them. But we also have things like CBT, which is cognitive behavioral therapy. That's where you go to a psychologist and kind of reframe the way of thinking about pain. Mindfulness is another kind of psychiatric technique or psychologic technique to try to deal with pain from a mental standpoint. And then there's also different types of exercise as well. We don't have great data to support these, although I would say acupuncture and cognitive behavioral therapy have the most evidence, followed by mindfulness. But none of these are really harmful as long as they're affordable. And so I think these are great outlets to have yet another way of thinking about how to deal with pain and really helping us avoid the last box, which is the opioid box, which I don't think is a good box to be in. Next slide. So these are a bunch of recommendations from our guideline to doctors, but I think it's important to understand it from a patient perspective because a lot of these can just be flipped right around. For instance, our first guidelines are to ask about pain. We're supposed to ask our patients about pain and set expectations. But it's good for patients to know that if you also have to bring it up. Sometimes physicians are uncomfortable and don't want to talk about it because it can be a hard subject. We're all frustrated that we can't make the pain go all the way away. And that brings the other thing, which is expectations. I think physicians understand that these medicines work a little bit and have some side effects too. And we don't have medicines that take the pain away or make it go almost all the way away. So that really shouldn't be the expectation. So when patients tell me their pain goes from a 6 to a 3, I'm doing cartwheels thinking this is the best thing ever. And sometimes patients are thinking, wait a minute, I want it to go to 0. And both of us are right. It's just, what are the expectations going in? I wish we had medicines that took you from a 6 to a 0. But what we have is medicines that take you from a 6 to a 5 or 4 or 3. Next slide. So so sleep and mood are important things to think about and treat as well as pain. So what we know is pain affects mood, affects sleep, and then vice versa. Mood and sleep affect pain. And it's this vicious cycle. And it's amazing how many people with pain have problems with both sleep and mood. And so if you're going to have success treating pain, which is already so difficult, you really also need to address these other things. Maximizing sleep, which can be a lot of different things. Maybe it's treating sleep apnea for the first time, which is so common in our population. Maybe it's making sure that you have good bed sleep hygiene. Anybody can Google, good sleep hygiene, and I think you'll find that you're probably not doing all of them. We all know what they should be, but it's things like going to bed at a regular bedtime, not being on screens before bedtime, um, also not eating and exercising right before bed, having the bed be, only for, having it quiet and cool and for sleeping, not for, having a TV or things like that. But that's just one example of, sleep is really one of our best treatments, and we should definitely not ignore it. And mood likewise. Some of the medicines help with mood as well. There's also psychotherapy, going to a psychologist, that can help there as well. But if you attack it from all three directions, people have much, much higher success. Next slide. And one of our big things was we have these four medicines classes that work, and multiple within each class. And so we should pick one, and if it doesn't work, go to another or add it on. If we're doing medicines, and we should consider. Actually, that's the next slide. Next slide. Or maybe it's one other slide after that. I'll wait for that point though. So this slide just says don't forget about the topical and other types of interventions. I think as doctors we're just so oral medicine centric that's all that's what we're used to. That's what patients expect. But there are topicals. There are other things. This lists some of the other things that have been studied. I'm not a big supporter of like glycerol trinite nitrite spray or citrullis or ginkgo, because the data is pretty poor. But there's at least one positive study on each of the things listed on this slide. Next. So this was the point I was trying to make early, which is because all these medicines work about the same, it means other factors are more important. Maybe you can get a 2-for-1. Some of these medicines treat seizures, some of them treat depression or anxiety, so might as well treat 2 things at once. Cost becomes a big thing. If there's like these things work the same, but this is $700 a month and this is $30 a month, like it's kind of insane to go for the $700 option. Usually if you want to know what not to take, just figure out what people are advertising on TV. Those are usually the ones you don't need. And then some of them have different side effect potential. So like gabapentin tends to one of the things is it can cause swelling in the feet. So if you already have problems with that, or that is something that would really bother you, maybe that's not the first one to try. Versus nortriptyline tends to cause dryness in the mouth, and so it really kind of depends on everybody's different about what they prefer. Yeah, next slide. So you don't really have to read it on the left because I've summarized it on the right, which is we often need to try multiple things, and I don't think patients often kind of understand that. Like the first one might not work, and it might be the second one or the third one or the fourth one, or we start doing topicals and combinations and things, and it might be that we don't really have a great option. We're here in 2025 where our treatments for pain are not perfect by any stretch of the imagination. So sometimes patients and doctors are both left frustrated with things not working in the end. But that doesn't mean we're holding something back. It's just the limitations of what we have here at this point in time. The other thing is it often takes 12 weeks to figure out if it works, which is 3 months, right? So I think people have the expectation that it'll work tomorrow, but a lot of these medicines take at least 30 days to start working, and then we like to adjust the dose and things. So unless there's side effects, I mean, obviously if you're having intolerable side effects, you would just stop it. But otherwise, you got to give it a college try at about 3 months. We should change classes. I told you most doctors even go from gabapentin to pregabalin. They're about the same thing. So we shouldn't do that. We should really change classes of medicines. Combinations also work. So if the first one works a little bit, add something to it. If the first one doesn't do anything at all, then we should just stop it. Next slide. And I really want to emphasize that we really shouldn't be doing opioids, including tramadol and tapentadol, which are opioids. So it's saying the same thing. This is something I've had an interesting training. I trained before doctors kind of became super liberal with opioids, and then now I'm seeing the kind of the pendulum come all the way back. And I think doctors before 1999 were right that opioids should be given in rare circumstances, at the lowest dose possible for the lowest time possible, because we do cause a lot of harm when we do anything but that. It's different in the end of life care situation. It's different in an emergency setting or an acute setting, but opioids really do cause a lot of problems. Next slide. So what are some of the unique challenges? So, one of the things, this study shows the number needed to treat and the number needed to harm. So number needed to treat means it takes 7 people given pregabalin to have one of them have half their pain go in half. So that kind of tells you, like, these medicines don't work as well as we want. It would be nice to have a number needed to treat of 2 or 3, but really they're more in the 6 or 7 range. But the number needed to harm is higher, which is good. So you need to give pregabalins to 17 people to have a side effect that bothers them bad. And so, the benefits outweigh the risks, but it'd be nice if the harms were even less, and it'd be nice if the treatments worked even more. And so I think that's what this kind of highlights. Once again, that they all work about the same. They have about the same tolerability, the same efficacy. They work about the same. But it would be nice if both these things were better, less side effects and more benefit. Next. And the other thing is we have limited medicines and interventions for the actual underlying cause. So we've just been talking about pain itself, but wouldn't it be better if we can make neuropathy better? And I know that's the main thing that we're interested here. There's diabetes. A lot of people have neuropathy. We don't know why. We call that idiopathic. Alcohol causes neuropathy, lots of causes of neuropathy, but we don't really have great treatments for a lot of these types of neuropathy. And the same can be true for radiculopathy in the nerve root in the back, mononeuropathy like carpal tunnel. At least that has surgery, but ulnar neuropathy at the elbow, not as good. Stroke, we have things that we can do in the very beginning, but then we don't have much to help with, and it can cause pain. MS, we've made a lot of strides, so maybe that's an exception, but at the same time, there's a lot of people with MS with lots of issues despite our good new treatments. So I hope that we really develop some good new treatments for neuropathy such that the nerves get better, and then we know the pain would get better along with that. Next slide. So what promising future options do we have? I think a lot of this has to do with the non-oral and topical medications. I think cognitive behavioral therapy has a lot of potential benefits. Some of this is going to a psychologist the traditional way. There are some online versions that might be just as good. Mindfulness, acupuncture, there's so little downsides to these, and they kind of help with pain and have been studied in lots of pain conditions, not just neuropathic pain. I would just be really skeptical if things are really expensive or cash only. Those are usually good signs that that we shouldn't be doing that. Next slide. And here's 2 examples. So I just kind of put in neuropathic pain into Google, and the top couple hits were the NeuroPro and the Neuropathy Light Therapy System. And basically, if you have a condition where the medicines that we have aren't perfect, and there are a lot of patients that keep having pain despite doing all the things doctors have, it's kind of a good situation for someone to try to take advantage of people. And that's what's happened here. You have 2 things here that just don't make any sense. The neuropathy light therapy system, that's basically like it lights up, and it's supposed to heal neuropathy and reduce inflammation. This is really not science. This is, an example of, a company able to market to people that are desperate. And then NeuroPro is supposed to be a massage slash stimulator, and it's supposed to help with blood flow to the feet. I mean, this just doesn't make any sense from a scientist standpoint or a doctor standpoint. But what I don't think people realize is we just don't regulate these things at all. The FDA does regulate devices a little bit, but mostly you have to show that they don't hurt people. Um, you don't really have to show that they help people. And so we have lots of devices out there that are available, but I would not recommend them. Next slide. And yeah, here is a review that kind of summarized all the things that we have besides medicines. And it is true that we have some data supporting cognitive behavioral therapy, mindfulness, treadmill exercise, and Tai Chi. But the studies aren't the greatest, so we do need to study this more. Next slide. All right, so we made it to the end. So if you're awake and we're able to put up with all my slides and some of the technical jargon, and I know it can be kind of difficult with all the TCAs, SNRIs, all that kind of stuff, but you made it to the end. And I think this summarizes most of the major points. So one thing is that neuropathic pain is unique. It's not the same as joint pain and skin pain and bone pain and even centralized pain like fibromyalgia. So it's different. It has different treatments, different causes, and but it's very common. So both primary care doctors and neurologists should be very familiar with it. We have these 4 classes of medicines that really work, all about the same. I mean, I don't think it could be more identical as far as how much it works and how much the side effects are. And that includes TCAs, SNRIs, gabapentinoids, and sodium channel blockers. And there's lots of medicines within each of these. So, you can even try, if one doesn't in the class doesn't work, I would recommend trying all 4 classes before doubling down and trying a second one within a class. But you could try 8 different medicines for neuropathic pain. Unfortunately, after that, you'd probably kind of exhaust our options at this point in 2025. And then, we have 2 topicals that have good evidence, capsaicin and lidocaine. And there are cheap options available. And I would highly encourage people to do the over-the-counter versions rather than the expensive versions. And I'd also encourage people to think about the cognitive behavioral therapy, mindfulness, exercise, and acupuncture, all of which have very little downsides and emerging data to support their use in neuropathic pain. Hopefully I've kind of emphasized that opioids really, including tramadol and tapentadol, shouldn't be what we reach for, neither for doctors or patients. And if you're on these medicines, trying to get off the medicines, as hard as that is probably a good goal. And even less dose is better than higher dose. Unfortunately, the number needed to treat and the number needed to harm, the good and the bad, are pretty close. So it's very clear to me that we need new treatments. Luckily, I'm on study sections at the National Institute of Health, NIH, and we're constantly trying to, have applications that are trying for the new therapy and try to do it without addiction potential, so they're not opioids, but it get even better pain relief than we have today. So I'm very encouraged that this is in the works, and NIH has put a lot of resources and energy behind that, and usually the results follow, but it's never as fast a pace as you or I want. And yeah, so that we need new treatments. Everybody recognizes that, but I think as long as patients and doctors both kind of realize the limitations of where we are and try to help people steer away from things that will harm them or cost a lot of money, I think that we'll do a lot better job than we're doing currently. And with that, I would love to take any questions.
Thank you so much, Dr. Hallahan. We really appreciate your expertise on this. I thought it was a very thorough presentation. So sorry. I'm actually just right now reviewing a lot of questions that are coming in. So I'm trying to, chew gum and talk at the same time, I think. So, the first question that I wanted to ask you is something that you didn't really touch on today, which is about biomarkers. And just curious if you are familiar with any biomarkers that can predict what type of treatments will be most effective for individuals suffering from neuropathy.
Ooh, that's a good one. So no is kind of the easy answer. we're, their neurofilament light chain is kind of the main biomarker for neuropathy and lots of nerve conditions. And so I think we're better at nerve injury than pain itself. What's fascinating about pain is, so people with diabetic neuropathy, only a third have pain and two-thirds don't. So we don't know why that is. And it's not like the severity of the nerve damage. And so pain is just a very interesting thing that has lots of things going into it. And my guess is it's going to be even harder to figure out a good biomarker for pain because the one for nerve injury should be much easier. And we are further along in that space, but we haven't figured that out. So I think pain is going to be even harder because it's not just about the level of nerve injury. There's lots that go into pain.
Yeah, understood. And you were talking a lot today about medications, and several folks have previously spoken with us about how to manage medication tolerance over time. And I know you see patients in your clinic firsthand, and obviously your peers do as well. Curious what kind of information you can share about that with folks that are possibly encountering that issue.
Yeah, so I don't know if it means like medicines that were working and then no longer work or just the side effect part. Do you have a sense of?
I think it's more the tolerance of the medication, right? So if you take the same thing every day, it's working, and then maybe after a year, 2 years, or however much that time period is, you're becoming tolerant to it. So you either need a higher or stronger dose, or perhaps it's just no longer being effective because your body has realized how it absorbs it and it's not reacting like it used to. So I'm curious if you could comment on that.
Yeah, it's a great question. So with opioids, that's absolutely the case. I mean, opioids, the tolerance issue is so high that what we find is people just need higher and higher and higher doses, and it just gets scarier and more downsides. So that's another reason to kind of stay away from opioids. The other medicines, less so, but obviously it can happen. And in that case, I think it's the time to add on another medicine and or switch it out. And it's not like you can't come back to that medicine, say, 5 years later, if or a few years later, if you're still in pain. But I think the key to know is we have more options. We have at least 4 medicine classes, 2 topicals, at least 3 good behavioral techniques. So 5, 9, that's at least 9 things right there. And then you can even take a second within a class. That might get you up to 13. So there's always something to try, but eventually we do kind of run out of evidence-based options.
And I'm curious, Dr. Callahan, do the different classes of drugs differ in the extent at which patients need to keep increasing their dose? Does that play in or influence the dosage and maybe that type of tolerance?
Just the opioids. I mean, opioids are
Okay,
kind of notorious for working and then not working, and your body like just is really good at getting rid of the opioid receptors, and so then you just need more and more and more. But the other medicines are all about the same. That tolerance is not a big issue, but it can happen. But we don't see it more in gabapentinoids than TCAs than SNRIs. It's that's very similar across the board.
understood. So, you didn't really talk much about scrambler therapy. We've had several questions coming through today to kind of learn more about that. Curious what your thoughts are as it relates to the management of painful symptoms.
Oh, unfortunately, I don't know what that is. Can you describe it to me?
So that's actually funny. I probably know I shouldn't describe it live right now to thousands of people. I feel less confident doing that, Dr. Callahan. But scrambler therapy is a type of therapy. I've known about it for as long as I've been with the organization now, for nearly 9 years. But if you're not familiar with it, then we should move on because I don't want you to comment on something that you don't have advice on.
Well, I see that it's electrical. I mean, that's why I think it kind of gets back to the device related stuff.
Yeah,
And that, we just don't study these things well. It's really kind of sad. I get a lot of these at the NIH as well, and people just aren't really willing to study them in a rigorous way. And it's really easy to do. And if you don't study it rigorously, it's easy to show that it works because of placebo
yes,
effects. And when
yes.
people do study it well, they don't work. And so I guess that's what that's the category I would, always open to it. I'm always hopeful. I mean, would it be nice to have, This
Yes.
would be a device that probably has less side effects and things. But I have not seen one that works convincingly, and I've seen a lot of bad studies. And I'm just saddened by how little we
Yeah.
regulate devices. I wish we had the same standard for pills because it's costly and people put a lot of time and energy into this. And so I would be very skeptical.
And I guess, as we kind of think about that and the future, right? And kind of thinking about the pipeline and maybe some new developments that you might be excited about, are you optimistic that maybe some of these overarching kind of barriers and restrictions are going to continue, or are they going to improve, especially with various wearable devices? I mean, how are you feeling about the future? I'm sure several patients are excited to know, hey, it might not be here today, but maybe it is tomorrow. So I'd love if you could kind of briefly share in a few minutes that we have remaining today about your thoughts on the pipeline and how hopefully there will be some more options.
Yeah, so I mean, what I'd say is, I mean, I put in a grant recently on a device, so it was someone else's idea, but I said as long as we're willing to study it really well, it would be great. So I'm hopeful that maybe we will figure it out. I just right now we have a lot of devices that are probably not legitimate. Um, and then there's something called the HEAL initiative, which was a big push by NIH to fund research in pain. And so when things like that happen, oftentimes there is a delay because science takes a long time, but then a new discoveries. When we tried to tackle HIV, we did it. It took a long time, but now HIV is a much different disease than when I trained. And so I'm very encouraged by the amount of money and resources the NIH has started to put into pain. That might be changing, but I'm always hopeful that some of these discoveries will be happening. And I get to see a lot of the applications come in, and so I guess I'm more hopeful than most because I get to see good applications come in, and might not work, but if we put in 5 good applications and one works, then that might set the field way forward. So I'm an optimist.
That's amazing. I actually am an optimist as well. I've actually personally sat on a couple of panels with the DoD and also in lots of conversations with the NIH. And I think it's really exciting to kind of see, and that's something that the Foundation's advocacy program continues to do to kind of help spread awareness about this, try to kind of encourage funding to be made available for peripheral neuropathy research. And obviously, we also are really supportive of early investigators and other types of grants, inclusive of using the biobank that we have so that we can really kind of help advance the knowledge in hopes that more treatments are discovered. So we're really excited to kind of be that bridge. And Dr. Callan, I'm so thrilled that you're a part of our community. And just again, thank you so very much for today.
Thanks, everyone.
And with that, I just want to remind everyone that this program has been recorded. You will get a copy of it in email. We're also going to upload it to the Foundation's website. We hope that you'll continue to support us so that we can keep providing these types of educational resources to you. And obviously, if you need anything, feel free to reach out to us. You know where to find us. Otherwise, thank you again to Lily for today's sponsorship and Dr. Callahan for his expertise. Have an amazing rest of your day, and I hope that you found this information helpful. Bye-bye.